So any doubts? Can we have a minute to start, and any doubts regarding the previous session or any other doubts?
Good evening, sir.
Hi, good evening. Yeah.
Sir, there's a question.
Yes, please.
Sir, how will we differentiate reactive hyperplasia from leukemia on flow
Okay. Reactive hyperplasia of what?
of lymphocytes, sir?
Mature lymphocytes?
Yes, sir.
Shall we see it in the second part of this course?
Okay, sir.
But if you are very eager, I'll tell you. See, there are some markers to check whether the population is clonal or not. Okay? For example, now let's assume a case of beta. You know what is beta? Benta. Okay? So it's a condition called beta syndrome, but fine. There is a excessive proliferation of B cells. Okay? Now there are markers in flow which can help us to say whether it is clonal or it is non-clonal. Okay? One such marker, or the very important marker for B cells, is your light chains, which is kappa lambda. Okay? Now you see how the expression of kappa lambda in the expanded B cell population. If the B cell population is showing both kappa and lambda, okay, for in a ratio of 2:1 or something like that, then it is likely to be polyclonal. Okay, that means it is reactive. Okay?
Okay, sir.
And if the complete population is restricted only to kappa or lambda, okay, then it is more likely a clonal population, which indicates it's a neoplastic population.
Okay, sir.
Okay, that is about P. For T, there is one more new marker for clonality, which I'll discuss in the second part of this course. Okay, now if I tell you, you'll get confused. Kappa lambda is a good example. So you can able to say whether it is reactive or neoplastic by kappa lambda for B cells. Right?
Okay, thank you, sir.
And regarding your question on the group, was it clear?
Yes, sir.
Perfect. So we have one more minute. Any doubts? You can ask any doubts. It's not like only with respect to.
Good evening, sir. Myself, Dr. Shadab.
Hi, doctor. Yes.
Sir, actually, CML can be used for diagnosis of CML flow cytometry.
I have a slide coming in the next lecture. See, CML, I'll tell you the absolute indication for using flow in CML is when it is going for accelerated or blast crisis, especially in blast crisis. When you find in morphology there are many blasts.
Okay, sir.
Okay, then you can use flow. One. Second, you have an ambiguity in your morphology, whether it is a myelocyte without granules or it is blast and you're not very confident on morphology, you can do flow. Second, and a very important and a least used indication for flow in CML is checking, differentiating whether it is CML or it is a leukemia reaction.
Okay, sir.
Okay, so mostly we don't, but that will be done by a technique. I'll tell you in the next lecture. I've included a slide in the next lecture. I'll tell you again. Okay.
Okay, sir. One more question, sir.
Please.
In bone marrow transplant, sir, we are doing CD34 counting, I think.
CD34 enumeration. CD34 enumeration in peripheral blood.
So
correct?
That, yes, sir. How we do that, sir? We will be informed about this later.
Well, this is an advanced flow cytometry course. We have Shadab, you have registered for basic also, no?
Yeah, sir. I have taken that.
You don't worry. I'll cover there. Okay, so it's a part of basic course. CD34 enumeration, lymphocyte subset analysis, BNH, HLA-B27, all will be covered there. Okay.
Okay, sir. Okay. Thank you very much.
Right. Thanks. So we'll start now. It's time. So last class we just saw about immunophenotyping of B lymphoblastic leukemias, and we also had a live discussion the next day. Today we'll be discussing on immunophenotyping of T lymphoblastic leukemia, and tomorrow we'll be having a live analysis of the cases. Okay. So as I'm going, if you have any doubts, you stop me there. I've enabled you to unmute yourself, so you can stop me anytime you want and you can ask your questions. Okay. Right. So I want this lecture again to be very interactive. Okay. Thanks. And be as informal as possible. Okay, now T acute lymphoblastic leukemia, just as an introduction slide, it's a neoplasm of precursor cells committed to the T cell lineage. Okay, so where does normal T cell maturation happen? Anyone? Where does the normal T cell maturation? Thymus, correct. So the normal B cell maturation happens in the marrow, bone marrow. Okay, the normal myeloid maturation happens in the bone marrow, whereas the T cell maturation is different from these two because it happens predominantly in the thymus. We have an advantage by that, I'll tell you in the subsequent slides. So it's a neoplasm of precursor cells committed to T cell lineage. Okay, so the clinical presentation may include, this is very important, you have hyperleukocytosis. Okay, whenever acute leukemia, when it is presenting, and when the patient has a count of around 2 lakhs, 3 lakhs, okay, with the mediastinal mass, most likely we are dealing with a case of T acute lymphoblastic leukemias. Okay, so hyperleukocytosis, extramedullary involvement, very importantly, the mediastinal mass because of the enlarged thymus, okay, and also lymph node enlargements are most common clinical presentation of T acute lymphoblastic leukemia. In contrast to B acute lymphoblastic leukemia, which presents more of B symptoms, weight loss, bone pains, and so on and so on. Okay, so when it is involving extramedullary tissue, lymph node, or a thyme or a mediastinal mass, it is most likely called a lymphoblastic lymphoma. Okay, T lymphoblastic lymphoma, and it should be distinguished from T acute lymphoblastic leukemia based on the degree of bone marrow involvement. Okay, when you find a large mediastinal mass and you have done a needle biopsy and found it to be TLBL, and when you do a marrow and check for any marrow involvement, and if it is less than 25%, you label the diagnosis as T lymphoblastic lymphoma. And when the marrow is involved with greater than 25% blast, then you call them as T acute lymphoblastic leukemia. Okay, so these are all theory, and I assume that you know all these things. Okay, so any doubts? Clear? So the criteria of 25% in the marrow, the 25% blast in the marrow will set a differentiation between TLBL and TALL. Okay, provided there is a mediastinal mass or a lymphadenopathy. Okay, so now going into immunophenotyping. So that slide is just for, yeah.
Sir, just one doubt. Why for acute myeloid more than 20% and a lymphoblastic more than 25%? Any?
Very good doubt. Even I don't know. See, even I have questioned this, but basically that's not the criteria to call acute leukemia or something. See, these cutoffs have been derived based on the studies, large multicentric studies projecting to the prognosis. Okay, so if you ask me a well definite answer, even I don't know. 20% is there even for your myeloid leukemias, but we are not here discussing on the definition of acute leukemia. Here it's something like to differentiate LBL and acute leukemia. Okay, so that is quite different from a definition of acute leukemia. Even for BALL, the definition, like we need 20% blast or something like that, right? So it's not like the definition of acute leukemia. It is basically to see whether the involvement of the marrow percentage. So if it is greater than 25%, we call that as TALL because the leukemic spread is dominating. When it is less than 25%, it means like that is not dominating over the mass. So we call it as TLBL. That is what I assume. But there is nothing like given in the textbook why it is 25%. I think it is basically by large multicentric trials which come out with that particular cutoff. Okay. So morphologically very similar to B lymphoid blast, except we commonly say that B lymphoid blast shows more clefting. Okay. But see, morphology, I'm not a very big fan because I have seen a lot of BALL also sometimes showing some indentations and clefts. So, but still, my textbook, clefting is more common in T lymphoid blast compared to B lymphoid blast. Okay. The samples include, see, this is all more about a repetition of last lecture. Okay. The samples include peripheral blood, bone marrow. Now, fluids, we get more commonly a pleural fluid in TALL because of the mediastinal mass and the mediastinal mass infiltrating the pleural cavity. Okay, whereas in BALL setting, The most common fluid what we receive is, what is that?
CSF.
CSF. Yeah, CSF is most commonly received in a BALL setting. In a DALL setting, at diagnostic point, we commonly receive a pleural fluid. Okay, there may be lymph node aspirates and tissue. So these are the samples which we may receive. Processing, acquisition, okay, and the panels is all very same as any acute leukemia. Okay, so I'll not be going very detailed because last time we discussed all these things. Okay, for acute leukemias, the panels, the processing, the acquisition, all remains to be the same. And we have discussed last lecture, so I'll not go very deep into it. If you have any doubts, you can ask me. Okay, and as with BALL or any acute leukemias, CD45 gives the first impression. So the first or the fourth universal plot what you will be using is side scatter versus CD45. That will give you an idea whether the blasts are there or not. Okay, but remember the expression of CD45 is relatively more compared to B lymphoid blast. Okay, I told you this. You know what is a blast region? The blast region is dedicated for predominantly the location of myeloid blast. Okay, B lymphoid blast will be falling in that blast region, or it can extend up to the CD45 negative region. Okay, whereas the T lymphoid blast will show relatively more CD45 compared to the B lymphoid blast. So TALL blast will be falling in the blast region, and most of the times it will be abutting the lymphocyte population. Okay, it will be slightly touching the lymphocyte population. Okay, I'll show you a diagram. So I'll show you a picture in the subsequent slide regarding that. Now, this is very important, and there are certain take-home messages which I'll be saying you need to note down, and that will be questioned at the end of the lecture. CD7 and cyto-CD3 is a very, very important marker for T acute lymphoblastic leukemia. Okay, you may not find a TALL which is CD7 negative. It is very, 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 very rare if you're finding a CD7 negative T acute lymphoblastic leukemia. If someone calls me, says like, sir, I've got a TALL, which is say they say all the markers HLA are negative, so and it is CD7 negative. I say like, no, you send me the plots. I want to see it again. CD7 TALL is very rare. So TALL invariably will be CD7 positive. Okay, so that is first point. Second point, cyto-CD3, you all know, we discussed this, it's a lineage specific marker for T cells, right? So cyto-CD3 also will be more likely positive, more likely. Okay, 99% or 90% of the cases, cyto-CD3 will be positive. Okay, only in a setting of ATP-ALL, which I'll be discussing later, the cyto-CD3 can be slightly dim or rarely negative. Getting my point? See, the points which I'm saying is very important. So note down. CD7 is invariably positive in all DALLs. Very, very, very rarely. I don't know. I have not seen a case. CD7 negative TALL is very rare. Very, very rare. Similarly, cyto-CD3 negative TALL is rare, and some cases of ATP-ALL can show dim cyto-CD3 expression or very rarely negative. Okay, the other markers of T cells, you know, surface CD3, CD2, CD5, 4, 8. Okay, so these are other markers which are supporting the diagnosis of T acute lymphoblastic leukemia, since these are all lineage associated markers. Okay, of course CD7 is a lineage associated marker, but the setting of TALL, CD7 is more likely positive. Okay, then you have immaturity markers as we had for BALL. So what are the immaturity markers for BALL? Anyone? Immaturity markers for BALL?
Sir, CD34 TDT.
Perfect. Perfect. Any other? Sorry?
CD10.
Perfect. CD10. And there are also some. So these three are very good markers. And there are some markers like what are the other immaturity markers of 45? You all forgot 45 very well. 45 is the one which gives you the very important immaturity marker, right? So 45 dim negative, that is a very important immaturity marker. Okay. So similarly in TALL you have CD34, TDT and 45. Okay. Now CD10 may not be as bright as TALL. Okay, and CD10 is positive only in some TALL which are what to say, which will be like cortical type or mature type. It will not be expressed in early TALL. I've been discussing these types in the subsequent slides. But to make my point, CD10 is not that bright, or the expression wise, the intensity of CD10 is less compared to BALL. But CD10 again is an immaturity marker for TALL. When you find a TALL with CD10, it means it is more likely a immature, and it denotes more likely a medullary ALL or a mature TALL. Okay, so and whenever you are interpreting these markers, immaturity markers, always see in constellation. Never go with one marker. As we had a discussion in the group, Dr. Preeti asked CD38. CD38 is an immaturity, evidence of immaturity marker when you have some other markers. For example, 1A or CD10. Okay, so you never go with only one marker. CD38 again in TALL, it more likely to be moderate positive. It will be more likely a moderate positivity. Okay, so I repeat the immaturity markers. CD34 TDT, as for BAL and DIM CD45, as for BLL, these three are excellent immaturity markers. CD1A comes in a type of TLL called cortical TLL. Similarly, CD10 comes as will help as an immaturity marker in a type of TLL called cortical TLL or medullary TLL. And CD38 is very good, but again, never go with only CD38. Okay, CD38 is just an associated marker. That's it. That will help you to confirm when other markers are present. Okay, so CD38, and this is again one more important take-home message. TALL is commonly HLA-DR negative. TALL is commonly HLA-DR negative. Any other leukemias which are HLA-DR negative? Anyone? APML. What other leukemia? Sorry? Yeah, correct. APML. Perfect. Any other leukemias which are HLA-DR negative? Come on. APML. Perfect. Sorry?
Erythroid megakaryocytosis.
Perfect. M6, M7. Very good. Great. And there is also a type of AML called mutated AML. NPM1 mutated AML, which I'll be discussing in the next class. Okay, so that is also HLA-DR negative. Okay, so TALL is HLA-DR negative. Okay, and in contrast, your BLL is invariably HLA-DR most likely positive. You are finding a BALL with HLA-DR negative blast, finding a BALL with blast showing negativity to HLA-DR is very rare. Okay, I would say it's BALL blast cannot be HLA-DR negative, but so I cannot use such a sentence, so I'm using it very rare. Okay, so if you find a BALL blast which is HLA-DR negative, something is wrong. Okay, maybe the expression has gone down, but it can't be completely negative. Getting my point? So TALL is HLA-DR negative, except a type of TLL called ETPLL, which can show HLA-DR expression, which is a very early T cell precursor ALL, which can show HLA-DR expression. Okay, and ETP can show aberrant myeloid markers, because during ETPLL, I'll tell you, ETPLL is something like it is a TALL arising from the very early progenitor. So at that time, it can show myeloid markers, it can show HLA-DR, and later as the cells mature, they will lose the myeloid markers and get committed more towards T cells. They become HLA-DR negative, and other leukemia, other type of TALL like pro-TALL, cortical TALL or medullary TALL, these all comes after that stage. Okay, so ETPLL is TALL arising from a very immature precursors. So it can show some myeloid markers as well as HLA-DR expression. Okay, so this slide is very important. Let me summarize. TALL is invariably CD7 positive. Cyto CD3 is a lineage specific marker for T, and most of your TALL is cyto CD3 positive, except some cases of ATPALL where cyto CD3 expression can go dim. But still, losing cyto CD3 is very rare. Second point. Third point, TALL is most likely HLA-DR negative, except ETPALL, which can show HLA-DR positivity. What is ETPLL? How to diagnose it? I'll tell you in the next slides. Okay. Immaturity markers, as with BALL, excellent immaturity markers are CD34, 45 and TDT. The other immaturity associated markers are CD1A, 10, 38. And never interpret immaturity markers alone. Okay, you can take CD34 as single immaturity marker. So any blast, if it's any abnormal population when it is expressing CD34, it confirms its immaturity. Apart from that, I would suggest you should come to a conclusion after finding all, after seeing all the markers. Okay. ETPLL can show aberrant myeloid markers, so you should be very careful. You should not jump to a diagnosis of MPAL T-bar myeloid. Okay. Any doubts?
So one doubt: the surface CD3 usually is present in mature T cells. So
Correct.
TALL also can have surface CD3 positivity.
Yeah, it can have. See, again, it can have. If there's a type called mature TALL. Of course, we are not using this names now. This mature TALL, cortical TALL, pro TALL, but the CD3 can be positive. Can be positive. More likely, it will be dim. It can be negative. Or I have seen cases where surface CD3 is moderate, and the TALLs with surface CD3 moderate expression. See, these are all a spectrum of maturation, starting from the common lymphoid progenitors till up to the cell which is about to mature. Okay, these blasts can arise from anywhere during the sequence of maturation. I'll show you the sequence of maturation of T cells. So the blast can arise anywhere from when the mutation occurs in that stage, then you have the phenotype of that particular cell. So I have seen, yes, to answer to your question, yes, I have seen surface CD3 positive TALs, even in moderate fashion, yes. Okay. Now, so this is the normal T cell maturation, and I discussed for B cells last class, and this is how these antigens or markers modulate as the cells mature. So what are the, and I'll tell you again, T cell maturation happens in the thymus and not in the marrow. Okay, so you have the prothymocyte, immature thymocyte, common thymocyte, mature thymocyte, and mature T cells. So, the leukemia can arise from this stage to this stage anyway. Say, for example, if the mutation arising in the prothymocyte stage, the arrest happens here, and you find more likely an ETPAL. When the mutation happens here, then you have a phenotype which is something like this. Okay, when the mutation happens here, then you have a cortical type ALL. When the mutation happens here, you have more likely a mature TALL phenotype. And when this is the case where you can have surface CD3 expression. Okay, in a good fashion, like normal T cells. Okay, so it all depends upon where the mutation is happening. Okay, now coming to this, again, I want to stress on the immaturity markers. You see CD7 first. CD7, that is why I say getting a CD7 negative TALL is very, very, very rare. And invariably, all TALL will be CD7 positive, because similar to 19 as we saw with BALL, CD7 is seen throughout the T cell maturation, almost in a similar intensity. This is a heat map, right? So this is almost like a similar intensity. If you ask me what are the immaturity associated markers, I would say CD45. So dim CD45 is an immaturity associated marker. Similarly, expression of CD34 is an immaturity associated marker, but you see CD34 is seen only in the very early stage, and later it may not be there. So I've got, so you cannot say this is not TALL because CD34 is absent in the blast. Though CD34 is absent in the blast, you need to see other immaturity markers. So I have got one down from one of the persons saying, like, sir, is this acute leukemia morphology? I found blast, sir, but in flow I'm not finding blast. I said, like, why? When we saw the blood, 34 is negative. So 34 is negative, sir, so there is no blast. No, 34 is just a marker. It's a stem cell marker. Yes, blast may show CD34, but all blast will not show CD34. It depends upon the maturation, like how mature the blast is also, right? So if there is a maturation arrest here and the mutation is happening here, and you get a cortical type phenotype, cortical TALL, 34 may be negative in that case, but still you may have a dim CD45, you can have TDT positivity, you can have CD1A expression. Okay, so these are the things which can help you to come to the diagnosis. Okay, so CD45, CD34, TDT, Okay, and with the maturation of T cells, first they are double negative. The early T cells are double negative. As they go to the cortical stage, they become double positive. That is, they will express both CD4 and CD8. Okay, and later when they are getting mature, they will express either 4 or either 8. So they have to select one among them. So that is how the normal maturation happens. So similarly, 4 and 8 double negative or 4 and 8 double positive can also act as a surrogate immaturity, provided you have an idea about other immaturity markers. Okay. Similarly, the expression of markers. See, CD3 is a marker which is expressed in mature T cells. So when CD3 is negative or dim, it is again an evidence of immaturity. Okay. So these are all very important points. Similarly, CD5. Okay. Dim CD5 is an indicator for immaturity. But again, these are all evidences. Okay. You cannot go with only one marker. So that is important. Now, this is what I said to you. Unlike B cell precursors, finding T cell precursors in marrow is abnormal. So, when you do a phenotyping or flow in the marrow and you are finding immature T cells, that is definitely disease. In B, what I said, in B, if you are finding blast and you are doing phenotyping in the marrow and you are finding B cells, immature B cells, okay, it could be normal hematogones. Okay, so but that is not the case with T cells, because immature or normal precursors for T cells are not there in the marrow. It is there only in the thymus. So when you find immature precursors of T cells in the marrow, it is invariably abnormal. It is leukemic. So for B, you have to differentiate it from hematogones. In T, no problem at all. If you find immature T cells, it's disease in the marrow. Okay, so that is the advantage I said you. Maturation happens in the thymus, so you don't find immature T cells in the marrow. Okay, that is the advantage of maturation happening in the thymus for flow site of interest. Okay, so they can easily pick up the disease, especially residual disease in the marrow. Okay, so unlike B cell precursors, finding T cell precursors in marrow is abnormal and represent disease or leukemic cells, because T cell maturation happens in the thymus. This makes detecting residual disease in TALL relatively easier compared to DAL and AML. Okay, so this is the normal maturation. So there is a common lymphoid progenitor which is there in the marrow, and a part of common lymphoid progenitors which has taken a path to go into T cell differentiation comes to the thymus. Okay, in the thymus, they first comes to the corticomedullary area where they are double negative. So this is the pro T cells. Okay, so as they mature, they go to a subcapsular zone and then come to the cortical zone. In cortical it becomes a double positive T cell where it expresses both CD4 and CD8. Whereas here it is double negative, 4 and 8 negative. Okay, so in the cortical area, then it needs to undergo positive selection after interacting with cortical epithelial cells. So now the T cells either have CD4 or CD8. So they have to lose one. Okay, so this is how the normal maturation happens. Okay, after the maturation, they leave the thymus and they come out in circulation. Okay, so I repeat again, maturation of T cells happens in the thymus and immature T cells are not found in the marrow. Okay, so we saw this in PALL phenotyping also. How do we differentiate between normal and neoplastic? Okay, so normal antigens expressed in consistent and reproducible patterns. Again, I'm telling you, this is not very important. This comes into play when you get a mediastinal mass for flow cytometry, because normal maturation is happening in the thymus, right? So when you're getting a mediastinal mass for flow cytometry, we have got, okay, basically the clinician will send you saying like mediastinal mass, query thymoma, query TLBL. In that case only, you have to find the maturation pattern for T cells. In marrow, I told you, maturation is not immature cells are not seen. So any immature cells you find, you will give it as disease. Whereas sometimes you will get some tissue from the thymus and they will ask you to say whether it is TLBL or it is thymoma. Okay. So at that point, you need to see the maturation patterns. Okay. So antigens expressed in consistent and reproducible patterns with maturation. If it is normal T cell precursors, in neoplastic, as we saw with BALL, it will be either the antigens or markers will be increased or decreased. For example, CD7, in neoplastic cells, the intensity of CD7 will be more. So increase CD7 expression. Similarly, if it is CD3 or CD5 in abnormal cells or in T lymphoid blast, the expression of CD5 and CD3 will be low. And asynchronous maturation pattern. Okay, you know that CD34 positive cells, T cells will be double negative. Okay, it is very immature T cell, so it will not show 4 or 8. When you find CD34 positive cells expressing 4 or 8 or both 4 and 8, it is definitely abnormal. So that is called asynchronous maturation pattern. I told you, right? In B cells, if you find CD34 positive B lymphoid blast, which is expressing, or B cell progenitor, which is expressing moderate CD20, then it becomes asynchronous maturation, because stage 1 hematogones which are CD34 positive will not show CD20. When it is expressing CD20, it can't be hematogones, it has to be disease. Similarly, in T cells, if there is asynchronous maturation, then it is abnormal. Apparent antigen expression. So if the particular T cell precursor is showing an aberrant antigen which it should not show, for example, it is showing a myeloid antigen, then it is abnormal. Okay. Similarly, any marker which is homogeneous expression, without that maturation pattern, if it is blotchy, homogeneous positivity as a cluster, thick, good, a big cluster, then it is definitely abnormal. So this we discussed in BALL also, and TL also the same rule applies, but this all come into play only when it is a thymic tissue. In marrow, any immature cell, T cells you find, it's disease. Okay, so this is a thymic tissue where see the maturation happening. So you find this, the pattern of maturation is like this. So there is CD5, then it slowly attains CD3, and it goes to the maturation stage. Similarly, after experiencing the thymic epithelial cells, the T cells, the immature T cells, either has to go for CD4 or CD8. Okay, so it goes like this. Similarly, CD45 is dim in T cell precursors, and as it matures, it attains CD45 and also attains CD3 simultaneously. Okay, slowly. So this is T cell pressure. Now, how does a leukemic or a TLBL, if a thymic tissue involved by TLBL, how that looks? That looks like this. You find a cluster of cells without no maturation patterns. Okay, see this is CD3 dim. You have normal T cells here, but this CD3 is dim, and 45 is, of course, I said you not 45 may not be as weak as we see in BALL. BALL can show a stronger CD45, however, slightly lower than normal T cells. It typically falls in the blast gate, or it falls slightly away. It just shows 45 slightly lower than normal lymphocytes. It can be till that. Okay, so 45 is slightly dimmer, and you find the population is 4 and 8 double negative. You find normal T cells here. This is CD8 positive T cells and CD4 positive T cells, and again CD3 is dim, and 5 is moderate. Okay, so this is how lymphoid blast or TLBL looks like when you do flow. Okay, so this is what I was saying. See, this is the CD45 side scatter pattern of BALL, where you find the blast lying in the blast region, or it can go up to the CD45 negative region. Whereas in TALL, the blast may show slightly higher CD45, so it can go and touch the lymphocytes, normal lymphocytes. Okay, it can go and touch the normal lymphocytes. So you need to purify the blast, you need to take up the blast correctly. Okay, so the point here is the 45 expression is relatively higher in T lymphoid blast compared to B lymphoid blast. Okay, so that's very important. So even in MRD, the residual disease can be CD45 moderate. So you should be very careful. You should not eliminate them saying like it's all mature T cells because CD45 is moderate. It can be CD45 moderate in contrast to B cells. Okay, so any doubts till now? Any doubts?
Sir?
Yes.
Sir, CD7 is a marker throughout the lineage, while Cyto CD3 is negative in the very early stage. So,
Yes.
Why can't we take CD7 as a lineage specific marker in place of Cyto?
Excellent question. I appreciate. Great question. So the question what asked was very relevant. She says like, you told like CD7 is expressed throughout the T cell maturation, and it is expressed throughout, whereas Cyto CD3 is expressed somewhere later. Okay, so I'll replay two things. We are not using surface CD3 for gating.
So Cyto CD3 is above, just below the CD5, that is CCD3. It is also initially dim.
Initially dim, true, very true, very true. Yeah, even in ETPLL, right? Okay. Now, why I'm not using CD7 is because CD7 is not a lineage specific or very specific to T cells. Even it can be seen in myeloid blast. Correct? It can be seen in a part of myeloid blast. Okay, some myeloid blast can show CD7 expression. I'll tell you what. See now, and CD7 is not very specific for T cells. It can be seen in some other myeloid cells also. So if you use CD7, invariably you will find a population of CD7 positive T cell, CD7 positive cells, which are negative for cyto CD3, negative for CD5, and negative for all the T cell markers. And it may mimic like a disease, especially during MRD assessment. Okay, and that is the reason why we are not taking CD7 as a gating marker or a lineage specific, using as a marker for gating, like CD19. We use CD19 for B cells, right? Because it is expressed throughout the B cells, and it will not be expressed by either normal myeloid cells or normal T cells, normal T cell precursors. That is why 19 we use. CD7, the problem is, as you rightly said, CD7 is expressed throughout the T cells. The problem with 7 is that it can be expressed by myeloid cells also. Not all. See, so don't take up a message like normal myeloid blast will show CD7. No, it's not like normal. A part or a small few normal myeloid blast can show CD7. And when you're taking
CD7, it as aberrant expression of CD7 in myeloid.
That's what I'm saying. See, this is normally for a beginner. This will not be said, but a part of normal myeloid blast can show CD7 in a very dim fashion. Okay, that cannot be taken as apparent. It's a part of normal maturation. Some CD7 is there. When to call that as an abnormal is when the CD7 is shown in a good moderate fashion or in a bright fashion, or when it is seen in a subset of myeloid blast which is CD38 negative, 33 negative, or 13 negative. Then it becomes an LAAP. Okay, so that is more related to MRD. Now, the answer to your question is, to make it very simple for all who's listening in, CD7, though it is constitutively, it's always expressed in the T cells from the immature to the mature T cells. We are not using CD7 because it is not very specific to T cells, like your cyto CD3 or CD19 in case of B cells. Because there are some cells, myeloid cells and some other cells which can show a dim CD7 expression. And when you're using CD7, you may pick up that population and you may falsely give that as disease. Okay, because it will not show any other T cell markers. So that is the reason why we are not taking CD7. That's a very good question actually.
Thank you.
Any other doubts? What we'll do, see, during our third part, we'll do MRD. At that time, you remind me. What we'll do two types of analysis. One, we'll get that CD7. Of course, CD7 is a gating marker, but I'll show you then what are the cells, non-T cells, which are showing CD7. Okay, remind me that time.
Right.
Any other doubts?
So the CD1A, this is a marker of immaturity as you told. So this is also a T cell maturity marker only.
CD1A, sorry, can your voice please?
CD1A, you said, you told that it's an immaturity marker.
I said as an immaturity marker. Okay.
Yeah, it's only for T cells, right?
Only for T cells.
Yeah.
CD1A, if you are also practicing histopathology, apart from LCH, okay, here CD1A is only for T cells. Though your AML or B cells is showing CD1A, then there is something problem with your fluorochrome. You need to check is it showing autofluorescence or something. And even if it shows 1A, I'm not bothered there. Okay. Perfect. So let's go for the
role for the T cell receptor.
Sorry.
T cell receptor in the role in ALL.
T cell receptor role in AML.
TALL.
TL. See, I'll tell you what, T cell receptors is very similar to surface CD3. T cell receptor, you see the expression of CD3 and TCR is a complex. These two are a complex basically. Okay, so TCR comes at the same time when surface CD3 comes. So when surface CD3 is positive, TCR will be positive. When TCR is negative, when surface CD3 is negative, TCR will be negative. Okay, doctor?
Yes, sir.
They both are a complex. So they both behave in the same fashion. When CD3 is positive, TCR will be positive. When CD3 is negative, surface CD3 is negative, TCR will be negative. So that cannot be immaturity marker or something. So this one I just said you. So I repeated, you will not have a separate acute leukemia panel for B. You will not have a separate acute leukemia for T. And similarly for myeloid. Acute leukemia is a panel made for acute leukemia. So any acute leukemia and you find blast, you directly need to go for that panel. And we saw these markers. So you have a backbone marker, CD45. You know what is the backbone marker. So I don't want to say that. For people who are just there, backbone marker is a marker which will be there in all your tubes. If you have a panel with 4 tubes, in all the 4 tubes, the backbone markers will be there in the same fluorochrome, and that will be able to help you to locate the population across all the tubes. Okay, first tube you have located, you have seen a population and you want to see it in the second tube, you can use that backbone markers to locate that population. Okay, so it is a marker which is present across all the tubes. If you if a panel contains 4 tubes, all the 4 tubes will have that marker in the same fluorochrome. Okay, so you have markers of immaturity, same 34 dim 45 TDT. If it is T lymphoid, you need to have 1A. Okay, some people what they do a 2 tube. I'll show you that. So CD1A is needed for a T lymphoid. 10 again may be seen in T lymphoid, but more likely and more intense in PALLs. Okay, so this we already saw. HLA-DR is very important in TALL. As I said, it will be more likely negative, except in ETP-ALL where it is positive. CD38 is another surrogate immaturity like marker, but you should not go only with CD38. I repeat, CD38 is more likely moderate positive in TALL. Okay, so this is about the markers. So acute leukemias have a common panel. So again, I'm showing you immaturity markers for TALL is more likely 34, TDT, 1A and 10. Okay, 38 you can use as an additional surrogate. 45 is again a immaturity marker as well as a backbone marker. And you have a lineage specific marker which is Cyto CD3. T-cell associate marker 7. Most all the TLL are invariably CD7 positive. Okay, I repeat. Then other markers are T-cell associated markers are CD5, 2, 3, 4, 8, TCL gamma delta. Even alpha beta you can have if you have space. And you should have B and myeloid markers. Why? For the diagnosis of ETP-ALL and also to find MPAL and also to find aberrancies. So for these 3 things you should have B and myeloid markers also run along with the T tube or T cell markers. Other markers HLA-DR which is likely negative in TALL except ETP-ALL and CD30. Okay. Now this is a panel. This one I just showed you in the last class. Same panel. So
Sir?
Yeah.
Hello.
Yes.
Sir, can you just say about CD?
Doctor? Hello? I couldn't hear you. I suppose there is a problem with your network connection. Is there a problem with yours or mine? Others can hear me, right?
Yes, sir.
Yes,
So
sir.
there is a problem. Doctor, can you just put your question in the chat box? I'll just go and if your network is fine, you can come back.
Sir, then CD2, is it a must marker? CD2 is a necessary marker?
No. I would say no. If you have, good. It's not mandatory. If you have it, it's good. Sometimes it may give you a small help to confirm it's T, because if you ask me, sir, I don't have space, should I mandatorily include CD2? I would say not needed. If you include, there may be some advantage to it's just another marker to confirm it's T. That's it. But again, it's not very specific. It can be apparently seen in AMLs also. But still, it's better if you have space in your panel, you can put it. So it's not mandatory, definitely. The other markers are mandatory. TCR gamma delta, why we have kept, or I would suggest you to keep in your panel, is because sometimes this hepatosplenic gamma delta T cell lymphoma, right? It has a blastic morphology. Normally we process acute leukemia for that. And if T cell gamma delta is not there, we'll be searching what is the diagnosis. If gamma delta is there and it is homogeneous positivity and it's not showing any immaturity markers and it's all mature, then you can be able to catch up the diagnosis of hepatosplenic gamma delta. That is the reason why I would suggest you to keep T cell gamma delta, but again, it depends upon the space on your panel. Okay, doctor, are you back?
Sir,
Yeah.
can you hear me?
Yeah, I
Sir,
can hear you.
what about CD40? Is it immature marker? In the beginning, you told CD38.
CD38.
Yeah, immature marker.
I didn't say it's an immature marker. It's like an immaturity. It can give you help of, it can suggest immaturity. But
Okay.
it is not a sole immaturity marker. I told you, right? Even in the group, I said that plasma cells can show bright CD38. Does that mean plasma cells are all immature cells? No.
No. Yeah.
So you should not interpret CD38 alone. You should see it with all other markers. Say, for example, if the blast is exhibiting TDT along with CD38, then you can take CD38 as a helping marker for immaturity when CD34 is negative. So don't interpret CD38 or in the matter, never interpret any one marker to take it as immature. Always have a constellation. The only one exception for this is CD34. When CD34 is positive, obviously it's immature.
Okay.
Right? Can we go ahead?
Yes, thank you.
Thank you. So this is a panel which I showed you. This is the T tube with surface CD3, CD5, 56, 8, TCR, gamma delta, 1A, 7, 4, 45. I have 38 in my first tube, so I'm not kept it in my T tube. 34 in my first tube and second tube. So it depends on your panel. So you need to cover up the markers which I showed you. Okay. See the backbone 45, it's all in one particular fluorogroup. Okay. So basically my point is you need to cover all these markers. And if needed, you need to process other markers. But in T, these markers will give you the diagnosis. And this is where a slightly panel which is slightly modified, where they have two tubes covering all important T and B cell markers with myeloid markers. So they have all myeloid markers here and some important T and B cell markers. With the results of these two tubes, they will process if it's showing CD19 positivity. Where is CD19 here? Yeah. CD19 is positive. Okay. And it is also showing what are the CD79A positivity, 22 positivity, and negative for all other markers. Then they can go for B specific tube where it has MRD markers and other markers like CD10 or something. Now, if it is showing positivity to CD7, where is CD7? CD7, along with cyto CD3. Where is cyto CD3? Cyto CD3. Okay. So 7 and cyto CD3 positive, 34 positive or 45 dim. 45 in the dimmer location or just nearby, just lying left side of your lymphocytes. Okay. In that case, you can process only the T specific tube and leave the B specific tube because anyhow you know it's going to be a TAL, so you can directly process T specific tube and not B specific tube. You can ask me, sir, will MPAL be missed? No, MPAL will not be missed because these these two tubes does not have any very important apparent markers or lineage specific markers in them. Because all the important markers are covered in these two tubes which will be run mandatorily for all cases. And based on the results of these two, if it is B, if it is AML, the diagnosis is done with these two tubes itself. Okay, if it is B, they will run the another tube. If it is T, they will run this tube and not this tube. So this is something, but again, but every time you need to go and see and you should ask your technician to run. So that is the disadvantage with this particular panel. Whereas here you can see the one which I have highlighted and this color, purple color is not needed. If it is APML, I would ask them to run an unstained tube. Otherwise, in acute leukemia, it's just 4 tubes. So these 4 tubes, I would suggest go over this because every time you cannot go check and ask them to run a B specific tube or a T specific tube, or your technician should be so good that she knows instantly what tube to be run next, whether B or T, based on the results of these 2 tubes. Okay. Now the other one is like Euroflow has come with a tube called acute leukemia orientation tube where it covers the lineage specific markers. So this tube you run for every case. If MPO is positive, you run the other myeloid markers. If it is positive for cyto CD3, you run all the other markers for T. And if it is positive for 17 and A and 19, you run the B cell markers. But again, this is like process get the results, then process next tube. So it's a two-stop solution, whereas processing a comprehensive panel is always good. So you also have an immaturity marker here, CD34, 45, that will tell you whether it's acute leukemia or not. And you also have surface CD3. So TLL may show dim surface CD3, so that will also tell you whether it's immature or not. Okay, now if you see how the markers and how it's common expression in TALL, you find, I told you right, CD7 is invariably positive in all TALLs. Even I don't accept it as 96.5, but I've taken it from an article, so I've just reproduced here. Almost I've never seen a TALL with CD7 negativity. So CD7 is very commonly expressed. Okay, and CD4 and 8 is double negative. It's around 6.7% of cases. Okay, it is morely seen in early T cell ALL because, and CD4 and 8 double positivity is seen more commonly. That means it's seen in cortical type ALL, which I'll be discussing now. Okay, single positivity, either 4 or 8 is again can be seen in 77.9% or 71.8%. So 1A can be seen in 66.7%. So when 1A is seen, it is cortical TALL. So that is, so you can put like this: cortical TLL constitutes 66.7% of all TLLs. CD2 again, it's expressed in most of the TALLs. It's around 90.4% times it is expressed. Cyto CD3, see, that is 84% it is expressed. Surface CD3 is expressed in 46% of the cases. 10 is expressed only in 57% of the cases. So it will be expressed in cortical TLL, and even some cortical TLL can show CD10 negativity. Clear? Any doubts? So HLA-DR, often it is negative, except in ETP, all other TLLs will show HLA-DR negativity. CD38 often positive, and it is of moderate expression. So I told you multiple times this. So these are all take-home messages. So now what is the diagnosis in this case? So I have highlighted the mature lymphocytes in green color and the blast in red color. So now someone has to tell me the expression patterns. I'll tell the marker, you have to tell what is the pattern, intensity of expression. CD1A?
Variable.
Variable, excellent. CD45?
Moderate to dim.
Moderate. Okay, this is bright. Usually lymphocytes are CD45 bright. Neutrophils are moderate. So this is moderate expression of 45. Okay. CD4.
Variable.
Yeah, variable. I would say because it's touching almost the normal CD4 cells. So I would say variable. CD8.
Moderate.
Moderate or dim? Again, I would say
Moderate.
yeah, moderate. That's like very difficult. Moderate or dim? I would say moderate to dim. That's it. Moderate to dim. And how about CD5?
Moderate. Dim.
Dim. This is definitely dim. Okay. See, everyone is following. If others wants to answer, they can answer. CD3.
Variable.
Heterogeneous.
Heterogeneous or variable, whatever you want to call. I use variable. Some people call heterogeneous. And how about CD17NA? CD17NA.
79 is
Negative.
If you want, you will take it as positive. If you want, not. I would say dim. Why you are hesitating? Is it a lineage specific marker for B? No, right? So, and this is dim positive, dim to negative. Since it's TALL, you don't want to take cyto79. This is a very common mistake people do. Which some markers they will fix to a diagnosis. It's TALL, and they will try to ignore other markers. Provided you have done your analysis right, was staining perfect, there is no autofluorescence, well compensated, then you need to interpret all the markers perfectly. This is dim CD79A positive. Okay, see, the normal B cells are lying here, the T cells are lying here, and you find this population from negative to dim area. So this is negative to dim, positive for negative to dim expression of cyto79A. And how about cyto CD3?
Moderate to bright.
Moderate to bright. Okay, so what is the diagnosis? You have any immaturity markers here? So here, I've not showed you.
CD8 has come.
Sorry?
CD8 has
And
come.
one is wait.
Oh, excellent. So you are looking for, so now, okay, CD8 has come. CD8 has come. So what's the diagnosis? Why you like immaturity markers? I have not showed you CD34. I have not showed you TDT. Okay. Without that, can't you make a diagnosis here? Because CD1A is an immaturity marker.
Yes.
1A is an immaturity marker. You have CD7 positivity, that too in a bright fashion. CD7 is bright, right? So this normal T cells, they are the blast are slightly on more, showing more expression than normal T cells. So CD7 is bright. Okay. CD3 is positive. You have surface CD3 in a variable fashion. You have cyto CD3, which is a lineage specific marker. You have expression of 8 and 4 in a slightly dimmer fashion. So that is again going towards immaturity. You have 5 in a dim fashion, that is going towards immaturity. 1A is positive. So what's the diagnosis?
TL.
TALL, right? What type of TALL? I'll show you that. Okay. For now, you leave that. So this is TALL. So most of the times when the TALL is of this mature, like it's like cortical TALL, may not show CD34. TDT will be positive. I have not shown TDT. Okay. So you have other evidences for immaturity here. 1A is positive. You see the expression of 5. It is slightly dimmer compared to normal T cells. You find CD3 in a variable fashion. So now if it is mature, it should find it, you should have CD3, that the whole blast should be showing CD3 in this place. You find here a variable fashion, so that is again evident, showing an evidence of immaturity. CD7 is bright, so you don't have a problem with CD7 is bright and cyto CD3 is positive. So you know it's T cell lineage. Definitely a T cell lineage. It can't be myeloid with aberrant T cell markers. Okay, so you have CD7 and cyto CD3, and cyto CD3 is lineage specific. So you are definitely, it's a T cell. And you have some immaturity markers like 1A, 45 is, this is what I said to you. The intensity of 45 is moderate in TALL. It can be dim or moderate. Okay, so it is definitely, 45 is higher expressed in T lymphoid blast compared to B lymphoid blast. It commonly abuts or touches the lymphocytes. Okay, so you have some immaturity evidence and you have a lineage specific evidence. So this is T acute lymphoblastic leukemia. Okay, and the red is the blast and the green is the normal lymphocytes. Any doubts? See, if you are a beginner and you are not following, and if you want to have some clarification, don't hesitate. You ask your doubts now. Okay.
79, CD 79, is this acceptable this amount of
Can you?
TLS?
Sorry. Can you repeat your question more loud and audible?
Hello?
Please? Yeah, please. Yeah.
Yeah. Sir, this CD 79 dim positivity, is it allowed?
It can come. See, it can come.
Indeed.
If the same population is not, if it is 90, this population is 90 negative, then I will not worry about this. I will never even worry about this. For example, if the blast is 19 bright or moderate positive, now I have a problem. Okay, to differentiate whether it's a B or T, which is very, very, very rare. But here the blast was 90 negative, so I don't even bother, and it can come. It can come. See, these are all abnormal populations, and they can show any apparent markers. Okay, that is why they have labeled some markers as lineage-specific markers, and some markers as lineage-associated or lineage markers. So definitely, cyto 79A is not a lineage-specific marker. Okay, so it can come. I have seen many cases where it comes, so don't bother about it.
So what about the intensity of CD3? So,
intensity of CD3 variable, right?
But sir, if it was from left to right, then it may be variable. But how can it be variable if it is going from up to down or down to up?
No. See, when you call variable is when you have a population trailing from negative to positive area.
So sir,
okay.
The negative area is of CD5, no?
No. See, now, since, okay, if I show you with size scatter, you can apply, you can easily understand. Now, see, forget this. Forget the x-axis marker at all. Now, CD3 is a y-axis marker. So, you need to interpret the marker here. So, which is the negative population for the y-axis marker? This population, right?
Yes.
This is the negative population for y-axis marker, and the positive population for y-axis marker is again the normal T cells, which is here, green color. Okay,
Yes, sir.
correct? So you forget about this x-axis marker, or you forget about CD5. Now this blast, which is red in color, it is trailing from the negative area. It is almost in the equal area from B cells, that is B cells, which is CD3 negative. So you find here the population of blast is starting from CD3 negative area, or it's falling same with the B cells, and it goes up to the normal T cells, which is expressing CD3.
Okay, sir.
So even up to down is also variable. It is not only when you are for an x-axis marker, it is right to left or left to right. For y-axis marker, it can be top to bottom. Okay.
Okay.
So that is about this. So even this is variable for CD1A. Okay. So you need to see the markers with respect to the controls. That's it. Now this is the classification of TL which I was showing you. Based on the markers, you can say. Okay. Now Pro-TALL is a very early, it's early ALL, TALL, where your cyto CD3 will be positive, CD7 will be positive, whereas the other markers all CD34 can be positive, whereas 1A, 4, 8 and surface CD3 will be negative, because it's a very early T cell. It's a leukemia arising from very early T cell, so it can show cyto CD3 positivity, CD7 positivity and 34 positivity. Pre-TALL is the next stage where you can have cyto CD3 positivity, 7 positivity, 34 again. So these two have a very similar phenotype, and I would club these two as early type TAL. Okay. I'm afraid to use that word early because you may confuse it with ETPL. ETP is much more earlier than early TAL. Okay. So this is something like early TAL arising from early T cell precursors. Whereas cortical is a stage where you start getting 1A. And it will be double positive, 4 and 8. Surface CD3 will be variable, positive to negative, because it is in the process of attaining surface CD3. Okay. Whereas when it becomes mature or medullary TALL, it will be positive for cyto CD3, it will be positive for CD7, and now once it goes to the medullary area, 1A will be lost. So 1A is interim, it will be expressed only in the cortical stage. So 1A is lost. 34 will be definitely lost because 34 is expressed only in the very early T cells. Okay. So common lymphoid progenitor with CD34 positive will come from the marrow, will come to the thymus. It retains that 34 for only some time. Then that 34 is lost. So even during the heat map I showed you, 34 is there in the T cells for very short duration. Okay. And then mature, it has to be either 4 positive or 8 positive. It has to be either 4 positive or 8 positive. It is not unlike cortical where it is double positive. Then surface CD3 will be moderate positive. That is, it almost lies with the mature T cells. Right? Now you tell me what. Now with that we'll go back to this. Now what type of TALL is this?
Cortical.
Yeah, because 1A is expressed. If the blast is expressing 1A, then it is definitely cortical TALL. You see, others are also matching. It is 4 and 8 double positive. Of course, the intensity is not up to the level of normal T cells, but still 8 is dim positive, 4 is variable positive. Surface CD3, I said you now, it's variable positive. So it is in the process of attaining. So the maturation, it is in the process of attaining CD3 positivity. 7 is bright. Cyto CD3 is moderate to bright. Okay, so this is cortical TAL. So again, this is ETPALL, which I'll be discussing separately. So which is almost like ALL arising from the cell which come recently from the bone marrow. So I told you, right? So common lymphoid progenitor from the marrow, once it decides it want to become a T cell, it goes into the thymus. When a leukemia is arising from that cell, that will be like an ETPALL. The later to that is early TALL, which includes this pro-T and pre-T. Then later is cortical TALL and mature TALL. So these are the subtypes of TAL, and this is how the phenotype differs from each other. Okay, forget ETPALL, which I'll tell you. Don't worry about that. So cortical, remember, double positive, 1A positive, and CD3 can be variable, positive or negative. So if any TALL blast, if it's 1A positive, it is cortical. Mature TALL is like the blast is there. It shows surface CD3 positivity, and it is either 4 or 8 positive, then it is morally mature. But now I'll tell you what, as I said for BALL, like pro BALL, common BALL, pre BALL, and similarly for T, as we saw now, pro TALL, early TALL, cortical TALL, this mature or medullary TALL, this is not much important. Not much important. Okay, if you give it as precursor T acute lymphoblastic leukemia, that's fine as per the WHO. But still, you should have a knowledge of it. That's why I'm covering it. Okay, now this one I showed you, like cortical TALL, we have discussed this. So, see, this is mature TALL, where you see the intensity of the CD3 of the blast is almost with the mature T cells. Here, mature T cells has not been shown. This is not my plot. So there is no mature T cells, but assume that this is the normal. So it is not variable as we saw with cortical. Here it is moderate expression of surface CD3. 7 is positive. It is 4 positive. Now you understand, if it is cortical, it should be double positive. Here it is only 4 positive. 8 is negative in the blast. The green is the blast population. See, here the blast is not, it's in the dim location. Okay, but most of the times the blast from the dim, it goes and touches the lymphocyte. But here it's fairly in the dim location. Okay, it is negative for 19. It is moderate for 5 positive. It is negative for HLA-DR. Remember HLA-DR, TALL, HLA-DR negative. Okay, so this is a type of mature TALL. Okay, the earlier one is a cortical TALL. Okay, as I said you, what matters most is differentiating ATPALL from other TALL. TALL you can call cortical, medullary, whatever. That is not, if you are going to miss it, it's not going to be a big blunder. But if you are going to miss calling an ATPALL, and if you just sign it out as TALL, then that going to become a problem because ATPALL cases has a poor prognosis, and you need to separate it from TALL. You need to give a pinpoint diagnosis of ATPALL. Okay. Now, what is ATPALL? ATPALL represents a disease subtype of TALL whereby the blasts are derived from the earliest T cell precursors in the thymus. So as I said you, the common lymphoid progenitor from the marrow comes into the thymus after it decides to become a T cell, and when a leukemic transformation happens at that stage after entering the thymus, that is called ATPALL. Since it just arrived from the marrow, it may carry some myeloid markers, it can carry some stem cell markers. Okay, are derived from the earliest T cell precursors in the thymus and have multi-lineage pluripotency. So they have the capability to differentiate into myeloid, or it can have the capability to differentiate to any lineage. So that is its capability to differentiate to multi-lineage pluripotency, hence show stem cell and myeloid markers. Understood? So what is the criteria? When do you want to call a TALL as a ATPALL? First, this is again take home message. So certain points I'm stressing upon, and this is one among points. So after this class, everyone should know what is ATPALL. What is ATP? Early T cell precursor ALL, acute lymphoblastic leukemia. Okay. So for calling ATPALL, 1A and 8 should be negative. First point, 8 and 1A should be negative. Sometimes a small subtype, a small population, a subset can be seen, but it should be less than 5%. Okay, but important point is it should be 1A and CD8 negative. 1A and CD8 negative. First point. Once it satisfies that, the second point is CD5 expression should be absent, or the expression should be less than 75%. The blast should show only CD5 expression of less than 75%. It should be either negative, or if it is showing CD5 expression, the blast, if it is showing CD5 expression, it should be less than 75%. So that is second criteria. Third, it should show one or more myeloid markers or stem cell marker. It should either show one myeloid marker or stem cell marker. So when the blast, a TALL blast is satisfying these three criteria, then you can label them as ATPALL. So what are those criteria? I repeat, it should be negative for 1A and CD8. It should be absent for CD5. If it is showing CD5 expression, it should be less than 75% in the blast. Third important point, it should either show stem cell marker or a myeloid marker in the blast. Okay, then you can call that particular TALL as ATP-ALL. Okay, so why you want to give a specific type of TLL, ATP-ALL in the report is, I said you like subtyping TALL into cortical, medullary may not be that important, but putting a TALL as ATP-ALL in the report is very important because these patients have a poor prognosis and these cases can be diagnosed only by flow cytometry. You by molecular or other means you cannot diagnose ATP-ALL. So when you're missing this, it may be considered as another TALL and they may continue with a standard regimen which may later end up in a relapse. But if you put it as ATP-ALL, they know this is an high risk case, so they can hit the tumor hard in the starting with the aggressive chemotherapy. So that is the reason why you need to give a specific diagnosis of ATP-ALL and not just TALL. So this is a classic case of ATP-ALL. So what is the first criteria? Someone?
CD1A and CD8 should be negative.
Perfect. So let's see. CD1A is negative. The red is the blast. The green is the normal lymphocytes. Okay. So you have CD4 positive T lymphocytes normal. CD8 positive T lymphocytes normal. Okay. Cytotoxic T cells, helper T cells, and the red is the blast. First, CD8 and 1A should be negative. 1A is negative. Agreed?
Yes, sir.
1A is negative. Okay. And what is the other point? 8 should be negative. Where is 8? 8 here. 8 is also negative. Okay, so some doubt may ring in someone's mind saying like, what mistake did CD4 did? Why we are not attributing to CD4 and only CD8? So if you see the ontogeny of T cells, CD8 is acquired a bit early. Okay, so that is the reason why we are taking CD8 as a marker. Okay, not CD4. So first criteria, CD1A negative, 8 is negative. 1A and 8 is negative. First criteria solved. Second criteria?
CD5.
CD5 expression should be negative. Or if it is expressing, it should be less than 75%. But here CD5 is not negative. It is expressed in a dim fashion. Correct? But what is the percentage? We'll come to that. Okay. So now we have a problem here. Second criteria, we don't know. So let's keep it there. Third, it should exhibit a stem cell marker or a myeloid marker. So the blast here is exhibiting CD34 in a variable fashion. So stem cell marker is seen in the blast. And it is also expressing CD33 in a subset or a part of the blast. So it is expressing a myeloid marker also. So third criteria is satisfied. First criteria is satisfied. Second, we don't know. We need to see the percentage of blast by drawing a quadrant. How much of this blast is showing CD5. So when I did that, so it is showing cyto CD3. Okay, I'll come back to that we'll finish before that. So now what I did, I just seen how much of the blast is showing CD5. It is just 25.12% of the blast is showing CD5. So it is also satisfied second criteria. So all the three criteria are satisfied. So can I label it as ATP-ALL?
Yes, sir.
Correct. But before doing that, you confirm it is TAL. It is showing lineage commitment to T. So how do you check that?
Cyto CD3 positivity.
The cyto CD3 is positive, but as seen with last cases where cyto CD3 was moderate positive sitting along with the normal T cells, here it is showing a variable positivity. Okay, so that is what I told you. Cyto CD3 will be positive, but it will be in a downregulated or a dim fashion. So here you see cyto CD3 is positive in the blast, but it is in a variable fashion.
So there
Okay,
will be
but-
some very early population. which is
Yeah,
cyto CD3
exactly. So it's a very early population. So they may show good 7, but cyto CD3 is in the process of acquisition. So it may show variable cyto CD3. So that is very important. And since it's showing myeloid markers, make sure it is cyto MPO negative. If it is cyto MPO positive, say for example, if the blast instead of lying here, if it is lying here, what do you call them?
double lineage.
It's a MPAL, mixed phenotype acute leukemia, T-bar myeloid. Okay, so since it's showing myeloid markers, make sure it is MPO negative. That is also very important. And what is the criteria to call it is positive for cyto CD3? That is also very important. What is the criteria to call the blast is cyto CD3 positive? The recent, the last, now this is going for a revision now in the current WHO, but the previous WHO says that a part of the blast should touch the normal T cells. Here is it touching? A part of this blast should touch normal T cells. Here is the normal T cells. Okay, normal T cells showing cyto-CD3. So as per the last criteria, the previous WHO criteria, a part of the blast should at least touch the normal T cell expression of cyto-CD3. Here you see the blast is touching the normal T cells. So you can take it as cyto-CD3 positive. Okay, so it is committed to T cells. Okay, so this is how you diagnose ETP-ALL. Any doubts?
Sir, can't we take double negative for CD4, CD8? Why we have taken only CD8 negative in the criteria?
That's what I said you, right? So, as per the criteria, these all criteria have been defined by multiple studies. So, 4 was not taken as, maybe 4 can be expressed in some cases of ETP-ALL. So, they have taken 8.
Markers.
Sorry?
It is a late marker. CD4 is acquired late. So, how can it be positive?
See, that is what I said you, right? It can be positive. Like, we don't have a clear evidence here. If you see that heat map, what I showed you some time back, see, CD4, it comes a bit early, I suppose. Sorry. CD4 comes a bit early. If you see the intensity, almost it's acquired the same stage, the cortical stage, but still the intensity of CD4 slightly comes earlier. That is the reason why they fix it to CD8. Might be.
Okay.
So, that is the reason.
Right.
Okay. So that is very important. This is very important. I thought like you'll be asking a doubt in this. So this is very important for a T cell commit cyto-CD3 positivity in ETP-ALL. The blast should at least touch the normal T cells. Okay, but with the current WHO, this is subjected to change. Don't ask me now. I'll tell you later. Okay, because even the only one when the book comes out, I need to know. I just got to know that it's gonna get changed. But the current criteria is the blast should touch cyto-CD3 level of normal T cells to call it as a commitment to T lineage or cyto-CD3 positivity. Okay. Any doubts?
Sir, HLA-DR can be considered as a stem cell marker?
Yes, you can consider not as a stem cell marker. It can come positive as in ETP-ALL. Yeah, you can consider that. HLA-DR it comes positive in ETP-ALL. Yes. But if you ask me, taking HLA-DR as a stem cell marker, I don't agree. But ETP-ALL HLA-DR will be positive because it's seen in very early T cells. That is those common lymphoid progenitor which is coming from the marrow to the thymus. At that time, HLA-DR is positive once it comes to the thymus. So HLA-DR is positive in ETP-ALL. That can be a helpful marker to confirm that these are all ETP-ALL. You have a TALL which is expressing HLA-DR, then it's most likely should be ETP-ALL. Okay, see, this is important. Okay, it should touch normal T cell expression up to the level of normal T cell. It should reach cyto-CD3. The blast should reach cyto-CD3 up to the level of normal T cells. Then only you can call cyto-CD3 positive. Okay, and 7 will be bright. That is very important. 7 is bright. Okay, right. Differentiating ETP-ALL from AML. Okay, so first point I said you, it should be MPO negative. It should be MPO negative. Okay, ETP-ALL show one or more myeloid markers like 13. I have seen a case. I'll show you now. 13, 33, 11B, and 117. It can show one or more myeloid markers. So definitely you may be confused to call this as the ETP-ALL or AML or MPAL, T-bar myeloid. So it can express HLA-DR. ETP-ALL can express HLA-DR. Okay.
So excuse me, sir.
Yeah, please.
We don't get myeloid markers like 13, 33, 11B, 117. Only we get the cyto-MPO. Then what would be we should consider, sir?
Could you? So you are not getting any myeloid markers, correct?
Right. Apart from like cyto-MPO is there, but all other myeloid.
Okay, cyto-MPO is positive. All other myeloid markers are negative. How about T and B?
T is there, sir. All like all ETP-ALL like picture is there, but no myeloid markers.
So your point is CD7 should be positive. Cyto-CD3 is positive, correct?
Yes, sir.
Myeloid markers all are negative.
Yes, sir.
Stem cell marker is there.
Stem cell marker is there. 34 is there, and
MPO is positive. Very rare case. Cyto-MPO without other myeloid markers. Very rare. Hypothetical question, but still if you stick on to the criteria, it is empal T bar myeloid. But I'll tell you what, that's a hypothetical question. You will never find MPO positivity without any myeloid markers.
Okay.
Without any myeloid markers, you will never find, practically impossible. I have answered your question theoretically.
Okay, sir.
Yeah. So
Thank you.
ETPALL will show one or more myeloid markers like 13, 33, 11B and 117. It can express HLA-DR. It can be negative for 5. It can be negative for 3. It can be negative for 2, 4 and 8. Now see, that is why I told, now you will be almost going towards myeloid because you have seen myeloid markers positive, HLA-DR is positive and T cell markers predominantly negative. If cyto CD3 is not in your panel, you will happily sign this case as myeloid leukemia. That is the importance of lineage tube. Now, if you run the lineage tube in this case, what happens? MPO is negative. And if cyto CD3 is positive, then you should sign this case as ATPALL. Understood? Now, I'm going to ask you a question. So, this is the picture. Now, cyto CD3 is negative, MPO is also negative. You asked me a question, I'm asking you a question again. Come on, answer. So this is the picture. This is, I don't know the diagnosis, so don't consider ATP. The blast is positive for 13, 33, 11B and 117. It is expressing HLA-DR. It is negative for 5, 3, 2, 4 and CD8. It is negative for MPO. It is negative for cyto CD3. If it is positive for cyto CD3, then I'll call it as ETPALL. If it is negative even for cyto CD3, then what would be the diagnosis?
So what is CD7?
CD7 is positive.
CD34.
CD34 is positive. CD7 is a good question. CD7 is a dim to moderate. So good, I'm happy that you asked CD7. CD7 is dim to moderate. What will you call that as?
So very early ALL.
Not ALL. Why you want to call ALL? What ALL markers are there for you to call it?
AML.
AML with aberrant 7.
AML.
AML
But lineage specific marker for AML is cyto MPO. Cyto MPO is negative.
It's a mixed lineage.
What makes it
Acute
lineage?
leukemia undifferentiated, sir.
So
Acute leukemia?
CD34 and
Very good.
CD45.
Acute leukemia undifferentiated. Acute leukemia undifferentiated or acute leukemia with minimal differentiation. That is the diagnosis. You find myeloid markers, it's minimally differentiated, hence cyto MPO has not been acquired yet. Okay, it is negative for T cell markers, even it is negative for the lineage specific T cell marker, which is cyto CD3. Then most likely diagnosis AML himself. I'll be discussing next week. So just like that. Just to wake you up, I said that. Okay, don't get confused. There is everything. Okay, so now, so ETPALL will mimic like AML, and who will come for the rescue? Cyto CD3. When cyto CD3 is positive, 7 is bright, and when it expresses myeloid marker, stem cell marker, whatever, and negative for all other T cell markers, still you want to call them as ETPALL, provided MPO is negative. Very important. Very important. So note down. Okay. Don't forget. Now this is a superb case which I had some time back. Okay. Now here you find this is all your plots. This is the blast, which is 75.56% of the total nucleated cells. I've just gated the lymphocytes here. So the blast is bright CD7. See here, there is a mistake. The normal lymphocytes are green in color. It's not. Then I change the color. Okay. Now the green is lymphocytes. Okay. But the blast is 7 bright, 1A negative. Okay. Here I've shown you. From here I've shown you the T cells in purple color and normal B cells in yellow color. Okay. Now how is the expression of CD34? CD34 is
Right.
See, the blast is traversing from here to there. Red is complete blast. I have isolated only the blast. Okay. So CD34 is variable, but predominant blast is CD34 bright. Okay. And 117, if you see, it is again dim to negative. See, this population of blast is showing 117 positive. See, as you're becoming more and more a flow cytometrist, you should not rely only on quadrants. Here you can see the negative population here. So this is CD117 positive, correct? So it is positive in a dim to negative fashion. So CD34 is positive, 117 is positive. It is CD7 bright, 1A is negative. Okay. 11B is expressed. 11B is expressed, correct? So these are normal granulocytes. Green here is normal neutrophils. Okay. So you find 11B is expressed. 4 and 8 is double negative. 7A, CD79A is negative in the blast. And MPO is negative. But the problem, so is it satisfying ETPAL? So what are the criteria one by one? So first it should be 1A and 8 negative. 1A is negative in the blast. 8 is negative in the blast. So first criteria is satisfied. Second, it should be CD5 negative, or if it is expressing CD5, it should be less than 75%. Very good. I have not included CD5 plot during preparation. Okay. Fine. Assuming that CD5 is negative. Okay. This case CD5 was negative. Okay. So you, pardon me, I have not included the plot. I have included other plots, but I forgot to add the CD5. CD5 is negative in this case. I know this case. Third is, what is the third criteria?
Myeloid markers expression.
Myeloid markers, you have plenty of myeloid markers. What do you want? You have 117 positivity, you have 11B positivity. Okay, so you have 2 myeloid markers. Of course, this case was 33 positive, I suppose. And you have stem cell markers, CD34 positivity. And this case was HLA-DR also positive, right? Have I shown HLA-DR? Oh my God, I have not shown HLA. But HLA-DR is also positive. Now, can I label this as ETPAL?
Yes, sir.
Very good. So I can label this as
MPO is negative.
MPO is negative. I can label as ETPAL, but the problem what I had is the blast population. I told you, right, for calling it a cyto-CD3 positive, the blast should touch the cyto-CD3 expression blast at least should touch normal T cells. So I would like the blast to come and touch up to this level. But here it's abruptly stopped here. There is evidence of cyto-CD3 positivity, but it has not touched this.
Subset is touching, I think.
Sorry?
One subset is touching.
But still it is, I told you now, as per the criteria, the blast, the intensity of cyto-CD3 in the blast, in a part of the blast should touch normal T cells. The normal T cells are here. So I would expect this subset to come still more higher and touch this. But still it is not, see, I'm talking about the criteria. Yeah.
Sir, can we consider those few dots which are there in the box?
Yeah, that you can't consider. In flow, you cannot consider. That is in MRD, it makes sense. In diagnostic, you cannot consider that.
Okay.
That could be noise also. But this case is an ATPL. Why? Because I'll tell you what. So, though the expected, that is why now the recent WHO book, Dr. Brent Hood is making a change. So I told you now, with the respect to the previous version, the criteria is this should at least touch the normal T cells, but now this is gonna go for a revision. So even you can see the blast is showing an attempt of cyto-CD3 expression as you rightly said in a subset. You see CD7. CD7 is very bright. So in that case, you can say take this CD7 brightness and MPO negativity in favor of ETPAL. Still, this is a case of ETPAL. Okay, so what I want to show you by this case is,
Can this be AML minimally differentiated?
It can't be. It can't be. It can't be. Very good. I was about to say that. You told it. It can't be AML because AML will not show bright CD7 like this. If it is an AML with aberrant 7, it will show a very dim CD7. It will show a dim CD7. It will not go beyond, the blast will not show CD7 beyond the level of normal T cells. Getting my point? So when you have bright CD7, and though 1A, cyto-CD3 is not coming up to that level, you still call it as ETPAL, provided CD7 is bright. This is very rare case, but I just want to show you this. Yeah, any doubts? Please, someone asked a doubt. Any doubts? Any doubts? Clear? So point is, when CD7 is bright, that is, the blast is expressing CD7 beyond the normal T cells, then it is most likely TAL. Most likely TAL. Okay. Now here you find as per the guideline, it should touch here. This should extend and touch here, but still it has not reached. It shows evidence of cyto-CD3 positivity, and with this CD7 brightness, I could still call this as ETPAL. That is my point. Okay. If blast expresses bright CD7, then it is likely TAL. When I say bright, what does it mean? The blast is showing CD7 expression beyond normal T cells. Okay, then it's likely to be TLL because AML with aberrant 7 will not be bright. Okay, aberrant CD7 expression AML will be dim or moderate and never bright. Bright CD7 is helpful in diagnosing few ETP-ALL cases, as I showed you, where the blast express myeloid markers and lack of surface T cell markers, even in the setting of dim cyto CD3. However, the blast should show some expression of cyto CD3. If the same population, if it is flat, something like this, still it could be a very tough case. But here you can see the evidence of cyto CD3 positivity in some of the blast. So I can take that as cyto CD3, evidence of some expression of cyto CD3 with bright CD7. I would put it again as ETP-ALL. Okay, so what is near ETP-ALL? We saw about ETP-ALL, right? Now what is near ETP-ALL? Near ETP-ALL is like when the blast is showing phenotype of TALL like myeloid markers, stem cell markers, 1A negative, 8 negative, but it is expressing phi. Normally it should express phi, it should be negative for phi, or it should express phi less than 75%, right? If the blast is expressing CD5 greater than 75% and it satisfies other criteria, then you call it as near ETP-ALL. That is, the blast is very close to ETP-ALL. That is called near ETP-ALL. Okay, so ETP-ALL show more frequent myeloid mutations. Like, because see the ETP-ALL, as I said you, it's very close to myeloid. It has just started to differentiate from to T, right? So it can more commonly show some myeloid mutations. If you're not getting the right diagnosis of ETP-ALL, then your clinician may ask you, is it myeloid? Because it frequently shows some myeloid mutations. Okay.
And
so
sir, that CD5 expression should be dim for near ETP.
See, even in ETP-ALL, it can be dim. What we are worried is the percentage. See, I showed you ETP-ALL here. Here, it is dim. Okay, it is dim expression. Correct? It's a ETP. It's not near ETP. It's ETP. But what made me to call it as ETP and not near ETP is because the phi expression in blast is just 25%. If this is 80%, if this dim expression is 80%, then I would call it as near ETP-ALL. Clear, doctor?
Okay, yes.
So analysis, you know this, same as B lymphoid blast. So you get the blast. See, again, I'm telling you, TALL, the blast will be touching the lymphocytes. It can be showing moderate expression. In BALL, it's very simple. It will be dim or it can be negative. Whereas in TALL, it can be dim, it can be moderate, or at times it can be overlap with lymphocytes. So you should be very careful in picking it up. Okay. Then identify the lineage of the blast. Then you refine the blast, check for the LAP. Okay. So that's it about TALL. I just want to cover mixed phenotype acute leukemia because next class in AML is quite lengthy. So I may not have time to cover mixed phenotype. So I just finished mixed phenotype with a couple of slides. Okay. Now, mixed phenotype acute leukemia is that where the blast is showing differentiation towards one or more lineages. Two lineages or three lineages, then you call it as mixed phenotype acute leukemia. As you all know, it is of two types. One is biphenotype acute leukemia, where you have one cluster of blast which is showing positivity to two lineages or three lineages. So you have one cluster of blast which is showing positivity to myeloid markers as well as T cell markers, or one cluster of blast which is showing positivity to myeloid markers and B cell markers. Then you call it as biphenotypic acute leukemia. What is bilineage acute leukemia is you have two subsets of blast. You have two blast clusters. One shows towards myeloid, the other shows to B or T. So one cluster, two lineages, biphenotypic. Two clusters, two lineages, or it is called bilineage acute leukemia. Okay, so flow cytometry immunophenotypic is essential for the diagnosis of MPAL. If you're not using a right panel and if you're not doing correct flow cytometry, or if you're not at all using flow, then MPAL cases will be mixed. Similarly, ETP cases will be missed. So it's flow is indispensable, and using a good panel of markers is very important. And accurate diagnosis highly depends upon the panel of markers you use. Okay, if you want to see, I have told you, right? It's a pediatric case, classic lymphoblastic leukemia. Just run B2. 19 positive, 10 positive, BAL. There could be an aberrant, or there can be a cytoplasmic MPO positivity in the blast. It is actually a case of MPAL. B bar myeloid. You have missed the myeloid completely. So don't sacrifice on the markers. It may be very bad on the diagnosis. Okay, so these are the types of MPAL where mixed phenotype acute leukemia, where the blast is showing differentiation to B and myeloid, or mixed phenotype acute leukemia where it shows differentiation towards T bar myeloid. Sometimes MPAL where the blast can show differentiation towards T, B and myeloid. Very rare, but still there is a case. Then before labeling as MPAL, you need to do cytogenetic workup. If the blasts are showing translocation 922, which is Philadelphia, still you need to label the diagnosis as MPAL with Philadelphia positive chromosome. Similarly, when the a case which you felt MPAL is showing MLL gene rearrangement or KMT2A gene rearrangement, you cannot put it as MPAL NOS. You need to call MPAL with MLL gene rearrangement. So this is very important. So basically, where the mutation happens, if the mutation is happening in the common myeloid progenitor or especially in the MS pluripotent stem cell, then you find the blast differentiating as the plasticity to differentiate to myeloid and lymphoid, and that is where this MPAL arises. Okay, so this was the earlier system what we used. This is Eagle system where we give 2 points for some markers based on the importance, and we give 1 point for some markers, and we give 0.5 points to some markers. So if you see, cyto-CD3 has 2 points. What's very funny is that CD79A is given 2 points, which is not right. Okay, so what happened is this current system is gone. This Eagle system is completely abolished. Now nobody is practicing it. It was some 5-6 years ago. Now it is not used. Okay. Now what we use is WHO's criteria for calling MPAL or lineage assignment. So myeloid, you know this, right? The lineage specific marker is myeloperoxidase. If it is monocytic differentiation, you at least need 2 markers of monocytes. Non-specific esterase 11C, 14, 64, so and so. If it is T cell lineage, we have been seeing all through this session, cytoplasmic CD3 is the lineage specific marker, or if it is mature enough, surface CD3 can be taken. Anyhow, CD3 is the lineage specific marker. For B lineage, it is not straightforward as MPO and CD3 for myeloid and T. For B, you need to have at least, if you have strong 19, you should have at least one of the other strong expressing markers like 17NA, 10 or cytoplasmic CD22. If the 19 is weak, then you need to have 2 strong expression of any of either CD79A or CD10 or cytoplasmic CD22. Okay, so this is how you give lineage, and it's you have to follow this criteria very strictly when you are calling an MPAL. Okay, if you want to give a blast myeloid bar D, it should show a myeloperoxidase and it should show cytoplasmic CD3. If you want to call myeloid and T with monocytic, means it should show 2 monocytic markers and cytoplasmic CD3. Okay, similarly for B, it should satisfy the 2 lineages what you are saying in MPAL. Okay, so lineage assessment can be challenging in some cases, and you should be very careful. And it constitutes only 5% of acute leukemias. Okay, so this one I showed you, acute undifferentiated is that does not express any markers considered to be lineage specific. Mixed phenotype, it satisfies MPAL, mixed phenotype acute leukemia, but by cytogenetics, if you get Philadelphia, then you need to put it under this category. Similarly, it satisfied mixed phenotype acute leukemia, but if it is MLL rearranged by cytogenetics, you need to put it under this category. If you have satisfied a B bar myeloid without any of the MLL gene rearrangement or Philadelphia, then you put it as B bar myeloid. Similarly, if it's satisfying T bar myeloid and if it is not showing any cytogenetic abnormality, put it as T myeloid NOS. Okay, so if the blast is showing some rare types, then you call it as rare types and other ambiguous lineage. So that I'm not going to discuss. So this is a case of biphenotypic where the population highlighted in this particular blue color. Okay, so you see this blast is showing positivity to CD19, strong CD19 positivity. It is also expressing CD33 in a variable fashion. It is showing CD13 in a dim fashion, dim positive. And you can see a part of this blast which is expressing strong 19 also expresses, a part of blast is expressing dim MPO. So this is one blast which is expressing B cell lineage as well as myeloid lineage. So this is a classic case of biphenotypic MPAL. Okay. And if you see this case, this is quite different. In the density plot, you can find two clusters. One is CD45 moderate, like dim, slightly higher than the other cluster. There are two clusters, right? 1, 2. And this is normal lymphocyte. If you see one of the subset, which is relatively the one which is more CD45 dim, is showing towards myeloid. Okay, it is expressing 117. It is expressing 34, 33. Okay, whereas the one which is showing slightly higher CD45 is showing CD19 expression. That too in a strong fashion. So this is the case of two blasts are there, and in these cases you can go back to morphology and see whether there are two different types of blast. Some may appear like lymphoid blast, some may appear like myeloid with slightly opened up chromatin. So this is two population of blast, one showing myeloid, one showing B. So this is bilineal type of acute MPAL. Okay, so you know what is the difference between biphenotypic now and bilineal. Okay, so this last time we had a good case shared from Dr. Shaini, right? So this is very similar case where we have a blast here, the blast which is CD34 positive. A subset of blast is expressing 117, and the blast is expressing CD13 in a dim fashion, or if you want to call variable, yeah, you can. Similarly, CD33 is expressed in a variable fashion. Of course, it is good 19 positive, moderate 19 positive. It is 10 positive, but in a variable fashion. So you have 10 starting at the blast, showing 10 in a good moderate positivity, and it extends till negative. So you have 10 in variable fashion. 19 is moderate. 34 is positive. Okay. MPO, a small subset is dim. Small subset, but that's just 2.95%. Okay. And 79A is dim positive. And CD33 is variable. 117 is, as we saw here, it's in a small subset positive. So what is the diagnosis here? What do you feel the diagnosis to be?
Bilineage, basal,
bilineage. I would call this as biphenotypic. You're not finding two subset of blasts, right? It's only one blast population showing markers. Okay, or you call it as MPAL to be safe. See, now if this MPO positivity is not there, if this positivity is not there and the complete population is MPO negative, I would call this as BALL with apparent myeloid markers. Okay, since a subset of blast is showing MPO positivity, now I am forced to give a diagnosis of MPAL, mixed phenotype acute leukemia. Okay, now you see this case is another case where you find a blast population which is CD19 negative, almost negative. It is expressing CD7, but however the expression is variable. It is 34 positive, but you see 7 it's somewhat dim to moderate, or it is variable. Okay, 117 is positive in predominant blast, so it is 34 1117 positive blast with some dim 7 or variable 7. CD33 is positive, moderate. 34 is also positive as we discussed. 4 is negative. 1A is negative. MPO is very good positive. MPO variable but good positive. MPO your negative controls are here, so 1A MPO is positive. MPO is positive. Cyto 79A is negative. The blasts are negative for 4 and 8. So what's the diagnosis in this case? Do we have a T cell marker? We have only CD7. Correct? CD3 is negative. Okay. Now what's the so it is not satisfying the criteria for T cells here because CD3 is negative. Correct, but it is satisfying the criteria for myeloid because MPO is positive. Okay, so the diagnosis for this case is AML with aberrant CD7. Okay, this is why we call aberrant CD7 because CD7 expression is not bright. CD7 expression is moderate to dim. So I can, it's still, if it is bright, then I would check the markers again, T cell markers again, but still it's dim to moderate, I would call, and MPO is very good positive. So I would put this case as AML with aberrant cell. Okay. So
what
AML.
about cyto CD3?
Sorry?
What about cyto CD3?
Cyto CD3. Actually, it's CD45 now. So CD45. It's not the pattern with cyto CD3. Okay, that's a very good question. Actually, this is surface CD3. This is not cyto CD3.
CD5 also.
Cyto is there.
Cyto CD3
Yes,
is
sir.
there with MPO.
Yeah.
and
So we don't
MPO.
have CD5 here. CD5 is there. Correct. Superb. So CD5 is dim to negative. Correct. CD5 is dim to negative. Now cyto CD3 is the marker to help us.
Cyto CD3 is there below this CD5 and it is touching the lymphoid population.
Sorry. Come again, please.
Cyto CD3 is there is below CD5 graph.
Yeah. Very good. Sorry, I
It's
didn't see
touching
this.
the population.
It's touching the population. Very good. So diagnosis is MPAL. T-bar myeloid. Perfect. Sorry. I didn't see this. Even I prepared this some time back, so I didn't remember that. Very good. So you are teaching me now. Great. I'm happy. So excellent. So we have MPO positivity and we have the blast which is almost touching the T cells. So you made my day. Superb. Though I missed, you picked up. So it is an MPAL. Okay. MPAL with myeloid per T. Excellent. So that is why I've kept the case post discussion of MPAL. Great. So any doubts?
Cases should be by phenotypic.
Yes, biphenotypic. Bilineal is very rare. MPAL with bilineage, 2 cluster. I have seen cases, but it's relatively rare compared to biphenotypic. Mostly it will be like one cluster of blast exhibiting T myeloid or B myeloid. And similarly, I'll tell you what, MPAL T bar B is very rare. You will not find an MPAL expressing T markers or B markers. That's very rare. So whenever you're coming up cases which are very rare, as I said, a TLL with CD7 dim or negative, a TLL with cyto CD3 negative, always check your markers. Question multiple times your processing and markers, then you sign out. Because rarer cases are very rare. So you can't get that. So when someone says me like I've got a rare case, you know what, this is it, I'd say like you check the markers again, rerun the tube. Or you send me the plots with the internal controls, let me have a look. So rare cases are very rare. Any
So in
doubts?
the previous case of MPL, that MPO positive cells were only 2%. So that
Yeah.
can be considered as MPO positive.
Yeah, you need to consider, because see, if you're not considering this, you need to consider, provided you have purified the blast well and you corrected all the compensation, still it is exhibiting, then you need to call it, because it is 2.95%. So if you want to eliminate, and this blast may resurge and cause a relapse at the time presenting as myeloid leukemia. So you need to consider this, or at least you put a point in the report saying like a subset of blast is showing MPO positivity, so MPAL cannot be rolled out, something like that. Otherwise, if you're just ignoring it because it's just 3%, then when it relapses, it's going to be a big problem.
And so this MPO is bright. It reaches the granulocyte. Is it because of that?
It is dim because you find the normal MPO sitting here. So it is slightly dim. See, I want to show you some ambiguous cases. That's why I got this CSS from, I suppose, one was one thing and other was from net, I suppose.
Sir, when defining B lineage, in the previous plots, we saw CD19 present, sir. So, but as per WHO criteria, we need to have 2 markers, strong CD19.
Correct. For which case, is this the same case you were discussing?
The previous one, sir.
This one? This one?
Yes, sir.
Perfect. Yeah, you are right. See, I have not shown you here, but see, here it is bright CD19. Okay. You got your point correct. The point you raised is right. If this particular population is not showing any of the other markers like 22, 10, 17NA, you will have a problem. But again, when a blast is showing this much of 19, it is already committed to B and it should show. It should show. Yeah, you're right. Theoretically, if you're speaking, if it's 10, 22, and again, I have a problem with my criteria. But by practical things and with whatever cases I've seen, when a blast is exhibiting this much 19 intensity, it will definitely show some B cell marker. It cannot be only 19 positive.
Thank you, sir.
This cannot be apparent. Any other doubts? I'm enjoying now. A lot of interactions, so superb. Any other doubts? So tomorrow we'll be discussing on live analysis. I've got some 2 or 3 cases for discussion tomorrow.